Okay, so this one should go even faster than the other one. This session's pretty much focused on osteoarthritis versus rheumatoid arthritis. The little chart here that's gonna kind of like a quick reference for comparison's sake. And then I also have like a bigger chart here, similar to the one we had for last session with extra information, like even more detailed information on the condition. So that can help as well, kind of compare and contrast them. So just kind of to look at it as kind of like the overview here. Osteoarthritis, the main thing to think about that one is this is a localized condition. It's essentially a wear and tear condition, while rheumatoid arthritis is an inflammatory systemic condition. So it comes with systemic symptoms, opposed to OA, which is pretty much focused on that joint that got worn down. So here we can see here it's OA compared to RA. RA is an autoimmune condition that starts to become prevalent at a younger age. Younger being kind of relative, so like maybe like late 20s, early 30s, around that time. While OA is because it's wear and tear, it's gonna be more common in people as they get older, or but it can also, because it is wear and tear, it could also happen to people that overuse their joints, or maybe in terms of genetics, just have worse joints or more predisposed to damaging their joints. Here, in terms of some of the pathophysiology slash where it kind of shows up, people with OA, it's going to be on like weight-bearing joints. So a lot of times the knees are popular, knees, hips, very popular, but it can also be in the hands, ankles, spines. And OA is also kind of in terms of like the hands, has these little notes that we'll go over as well. While it's an inflammatory condition, it has inflammation in the synovial tissue, and that inflammation leads to destruction or and the surrounding cartilage and bone, leading to joints that are deformed from inflammation. OA will typically be unilateral and asymmetrical, while your RA, because it's systemic, it's going to be symmetrical. So it'll be usually if you're having that RA damage in your hands, it's going to be both hands. While with OA, it might be that one of your hands you use more than the other. Or you wear and tear the cartilage more. So it's your right hand that has OA or your right knee that has OA, while RA would have that inflammation damage on both. So some other again key factors would be this is a mechanical in terms of OA. So you could hear crepitus. So that's when you kind of flex that knee, you'll hear it kind of crackle, snap, crackle, popping, cracking. While RA is that inflammatory comes with things such as fatigue and low-grade fever. So common things that occur with autoimmune inflammatory conditions. So in terms of textbook, OA is cool, warm to the like cool, kind of like I say cool slash warm as in normal body temperature. So a normal body temperature to the touch because it's not an inflammatory condition unless they are actively moving it around and causing it to become inflamed from from the wear. While RA, even if they're not moving it around, the joints will feel a little bit warmer to the touch because it's a consistently systemic inflammatory condition. And then at the bottom of the chart, OA mentions here the way to look at it is they do an X-ray on the bone. They will see these things on it. So the space of the joint narrowing down because it's being worn and it's being worn down. Bone spurs, formation of bone spurs, cysts, little nodes as well. While ways for RA to be looked at includes a lot of inflammatory markers. So rheumatoid factor will come down positive. Your ANA titers will come out positive, and your ESR and CRP, which are some of your inflammation markers, will come back elevated. Okay, so that's the general overview with the little chart. Here again, just kind of writing it down: osteoarthritis, non-inflammatory, localized arthritis, progressive joint deterioration. It's going to affect your range of motion, mobility, and a lot of time will come with pain. So again, associated with age, normal wear and tear, obesity, because the extra weight wears down joints, and as well as general injury. So someone that might be like an athlete, is constantly doing exercise, putting stress on their knees, putting stress on those weight bearing joints, can lead to osteoarthritis that way. So in terms of manifestations, there's a few that are kind of associated in particular with your OA as opposed to your RA. So what are those? So some of the some of the main things that you think about. So there's like how they feel in the morning. So I think that's one of the ones to keep in mind. So what do you guys know about the that one for OA?
For OA, that would be pain after activity, so end of day pain. And then RA is pain after rest, so in the morning.
Yeah, and in terms of textbook, they kind of focus down on the morning stiffness, but you're right that with OA, this is the pain isn't directly inflammatory, but if they're still moving around on the joint, it will cause inflammation from the wearing and tearing. Um, but yeah, so while RA is just kind of consistently happening that way. In terms of like stiffness, OA is characterized by the morning stiffness. So they'll be stiff. Yeah, they'll have pain in the morning that gets a little bit better. It's kind of like that stiffness, kind of like essentially you can kind of think of their joints kind of like maybe being like two gears that don't have enough oil. So in the morning they just get up and it's harder to move around. They're more stiff. They don't have the little cartilage to soften up the movement. So it ends up having morning stiffness. That that stiffness will decrease with the movement, but again, that movement might also cause them some pain. So morning stiffness, and especially in terms of like lecture wise, they want you to think of it as morning stiffness that happens less than 30 seconds, that decreases with movement and activity. So they loosen up, but this will cause pain. Okay. So let me see what else you guys mentioned here. Yeah, it's unilateral. So that's a key thing with that. Ooh, where's Chris? Ooh.
You're gonna get a whole one.
Wait, I don't get a whole one?
Oh,
What? Oh,
not for you.
okay.
Have some.
I will have some. Yeah.
A little nip right here. They're not fully done, fully.
Okay. This is unilateral. Unilateral. Manifests from wear and tear. Yep. So the I won't include it just because I guess it's like unilateral wear and tear. I guess I'll include it here. What about the note? I think it ends up. I think OA was slightly mentioned in 220. I don't know if the knowledge of the notes came up, but that's like one of the other manifestations is the Heberden's and Bouchard's notes. Let me. Oh, really? Damn. I have a picture, and the way honestly I think about it is literally just the one that starts with a B is closer to the to your bodies because it's A B. Like think about like alphabetical order. The B one's closer and the H one's farther. That's literally how I think of it. I'm not sure why they even bother differentiating it, but if for some reason that comes up, that's how I think of it. I just think of B comes before H in the alphabet, so in terms of your finger, it's earlier on in your finger. Some other ones that we mentioned is the crepitations and why this one's related. Crepitations, decreased range of motion. With RA, you see a lot of contraction. I know like so my mom has OA and RA. I know that. Oh, speaking of rice crackle pop, I'm having rice krispies, yeah. So the crepitations is like the crackling on the joints. Yeah, but a lot of what we talked about is actually already in this upper chart, so it's kind of just repetition a little bit. Because we already talked about some of the diagnostics being the bone spurs, joint, the X-ray showing the, oh, I kind of already mentioned this here, joint space narrowing, the bone spurs. Honestly, in terms of this condition, it's relatively basic. There's not really any, there's really not too many um things that we have here that we didn't already mention. And then this is saying like it's diagnosed by your signs and symptoms and some of your labs. So maybe they'll do some labs for RA just to rule it out. So maybe you'll have like these labs come back negative. This could be maybe be normal to maybe slightly elevated just because maybe they're if they're still moving on it, it might cause some inflammation. But it's just a combination of these ruling out RA alongside the signs and symptoms, and they'll do an X-ray. They'll be able to diagnose the osteoarthritis. Other than that, it's pretty basic, if I'm being honest. There's not much to really go about. I guess a lot of it kind of goes with your management here. So in terms of management for osteoarthritis, what medications would be recommended here? Okay. Yeah, you can use steroids and NSAIDs. I'll put in order of I'll kind of separate between first line, second line, and third line just to have some context. So in terms of so we mentioned NSAIDs and we mentioned steroids. In terms of first line, second line, third line, which ones, where would they go? So that's an important thing to know here is Tylenol is actually first line. The reasoning why is because again, this condition is not inherently inflammatory. Unlike RA, which is a systemic inflammation disease, this is purely wear and tear. So this condition is not inherently inflammatory. So the NSAIDs are not as recommended, which is why they're lower down the line. So NSAIDs are considered second line. And then your third line includes steroids and opioids. Because still, you can have inflammation if you're still kind of going on it, and your NSAIDs can still help you with the pain. But the Tylenol is gonna help with the pain without, having obviously Tylenol has its own issues with how it can affect your liver and stuff. but your NSAIDs can affect your kidneys and your GI bleeds and this other stuff. And again, because the condition's not inherently inflammatory, Tylenol's going to be better. So I believe the lidocaine is actually in lines with the first line. So it's kind of like the inflammatory stuff is less in the totem pole. Some of the other stuff that helps with directly just pain is closer in the totem pole. And then the opiates is for like extreme pain, so that would be towards the end because again, a lot of it kind of has to do with the management of the like the pain's not going to be active all the time. It's going to be active when they're moving, so they don't really need to have like routine opioids for that. So you can have like topical lidocaine kind of listed here. We mentioned this, so you wanna monitor LFTs, liver function tests, because Tylenol can have an effect on that. I think Josh already mentioned how you want to assess and monitor for like kidney labs. So your um BUN over creatinine, kidney labs, and GI bleed. BUN over creatinine. And then the steroids. So, when it comes to steroids, again, we are going to be thinking about how, what are some side effects of steroids, topical steroids? But keep in mind, it's typically not recommended. The moon phase, suppress immune function. Cushing's is like, you'd have to be on you'd have to be on it for like a pretty solid amount of time to get Cushing's, but yeah, that can be something that can happen. So kind of watch out. Hyperglycemia, yeah, so that can cause hyperglycemia, impaired immunity, RF, RF, risk for. Oh, I've never seen that one. I've actually never seen that one. Yeah, so like we talked about, basically think a lot about like a lot of your Cushing's condition. So it might not directly cause Cushing's, but it will cause like without like long-term high dose exposure to it, but it can cause some of the signs and symptoms because it's just building up a bunch of cortisol. So yeah, so bleeding risk, all the things, and it can technically cause Cushing syndrome when it's really high dose, long term, but it probably wouldn't be in this condition just because again, it's not really recommended for OA because again, the key again, the very key difference is OA is not inherently inflammatory. Okay, so in terms of pharmacological, we got those. You mentioned why this is something to watch out for. And then I think Josh started kind of talking about some of the effective non-pharmacological. So that would include things such as proper nutrition. We mentioned exercise, so range of motion exercises and positioning. So kind of exacerbating it can cause the pain to happen, but it can be good to also decrease the stiffness. So it's kind of like moving it around will cause pain from wear and tear, but the stiffness pain is probably worse. So we want to make sure it's not stiff. And then once you try to get it not stiff, but also try not to aggravate it too much. So it's kind of like a little balance. But the pain from not moving is going to be definitely worse than the pain from moving it. But so it's just kind of like keeping track of that. What about other treatments, non-pharmacological pain treatments that might be effective? So if someone has pain in a specific area, what's something we can do without immediately going to pain meds? Yeah. So perfect. So we're gonna have Heat or cold. So cold for some swelling and heat for stiffness. Because the heat is going to get the blood flow going. It's going to help a little bit more with the stiffness. Too much cold can cause stiffness. So cold, if it's swollen because they've aggravated it too hard, then the cold's going to help with that. But if they're overly stiff, then the heat is going to be a bit more effective. Something else that can be done is like hot shower, like warm showers in the morning can help with the stiffness as well. What triggers like alcohol? Maybe you're thinking of RA? The main trigger here would be movement. It's okay. You actually have COVID? Oh, wait, no, you said maybe. It's like, well, ah, not really. I mean, a COX-2 inhibitor, like Celebrex, that's basically an NSAID. Those are, yeah, so the difference between the typical NSAIDs like ibuprofen and Celebrex, the NSAIDs are COX-1. They affect COX-1 and COX-2, while the COX-2 inhibitors, as in their name, only affect COX-1. So the COX-2 inhibitors are, I believe, um, effective with the pain, but have a lessened risk of doing something else. I don't know if it's lessened risk of GI bleeds. I'd have to double check up on that, but um, let me double check up. At the top of my head, that's what I remember from that. Yes, I believe the Cox. Yeah, so from I looked it up here, the the typical NSAIDs would affect inhibit COX-1 and COX-2. COX-1 has um functions in protection of the stomach lining. So the typical NSAIDs like ibuprofen, that's why they cause GI bleeds. COX-2 inhibitors are going to be essentially it's going to be most of the benefits with less of the downsides. But over time, if you're getting COX-2 inhibitors, again, high dose, long periods of time, kind of like a lot of your other receptors and hormones, they would start affecting the COX-1 receptors and then lead to some of the same effects. So, a black box warning on the Celebrex will still be GI bleeds, but it should be lessened. It should have less GI discomfort and less risk of bleeding compared to an ibuprofen or anything. And then let me see what you guys. So we can use braces and splints, perhaps the IP can come down on the red meat. Yeah, anything that decreases inflammation would help. But again, this is not inherently an inflammatory disease, but it doesn't hurt to do so. Inflammation comes from stressing out the joints. But naturally, if we're trying to keep them from being stiff, we are going to have to move them. So that can cause pain from that. But, so we mentioned proper nutrition, obese. That could be that's one. I guess proper nutrition kind of goes with that. They're obese, weight loss. If they need to, then that's when we're gonna do potential surgery with to replace the joint. And then I believe they told you to review a bit of your post-op hip surgery and stuff. So I'm just going to straight up copy paste it and we'll just kind of talk about it. We'll just kind of copy paste that for review of your hip replacement and whatnot. So some of this might be a little extra, but this is kind of what I got. So a total joint arthroplasty, it's going to help with the mobility. As with a lot of surgeries, it's if they have an active infection, they're probably not going to do it. People with diabetes, hypertension, higher risk. Again, this is review from first semester. I would say, in general, with a lot of these um, ortho kind of conditions, you always want to think about acute compartment syndrome. So you're always thinking about the six P's CMS. How is their circulation? Are they able to move? How is their sensation? Do they have the pulse? Are they having the pins and needles feeling? Do they have breakthrough pain and that the pain medication doesn't hit? Are they swollen, overly swollen on one side? So you always compare right versus left. Just key thing would be make sure you check the skin, vital signs, CMS, early ambulations, assess for infection and bleeding because it's a surgery. So here are some of the precautions. So here would be risk of DVT. So that's why early ambulation is going to be good. If they're not moving that around, maybe they can form a clot. So from there, something that they could do would be like isometric exercises could be good. Um, SCD on because let's say that they had surgery on their leg and the SCDs would cause pain on the leg. So maybe we can have them just kind of like try to flex the try to flex the calves to try to get something going. And then general hip precaution. So this is what I think is probably something that could come up. It's just like important things like don't cross the legs, no bending of their spine past 90 degrees. Try not to sit or stand for long periods of time, not twisting around in the bed. Only out of the bed with assistance. So we're gonna have probably PT with them. Um, all of these things. And again, key thing is gonna be your CMS or circulation, mobility, sensation, and the six P's, which I believe will be, yeah, I think that's a good thing. The pillow to kind of make it more easy for them to remember also that they shouldn't be um abducting or adducting their leg. So keep it within that area. So I'll probably add that in. So things to keep in mind. Some of the complications would be dislocation of that new hip, bleeding, DVT infection, pressure injuries from not moving. Although that's probably with um watching out more for like older people who have thinner skin, might already kind of have start of some pressure injuries and all those old people that come from sniffs, they got like pony pressure injuries. Blah blah blah. Some extra information here. Dislocation can present as shortening of the leg. So that could be a type of question. I think they might have like a Kaplan question like that, where oh, the patient's leg is shorter on one side, and so it could be a sign of dislocation. Sudden severe pain, feeling the hip pop. And then here just general post-op. So again, we talked about the neurovascular check, CMS, and the six P's. And I believe I wrote down the six P's in here somewhere for those that need a refresher. If not, I'll just write them down now because I didn't do that over here. So the six P's. So that would be the pain that is unaffected by medication. So opioids. So strong opioids don't do anything to the pain. So it's like a breakthrough pain. Breakthrough pain. We're gonna have paresthesia. So that's that pins and needles feeling. Uh, they call it poikilothermia. So that's the difference in body temp. So in limb. So one limb feels really hot and inflamed. The other one feels um cold. So like just like a difference. So again, just comparison of right versus left. In this case, it might be cold from lack of circulation. So maybe the left one is warm and dry. The other one is feeling dry but cold. Another one that could come up is so I said that, we said this, poikilothermia, um, paralysis, are not able to wiggle their toes, not able to move. Pulselessness, they have the whatever distal pulse is nearby that area, the pulse isn't being felt, or it's very weak, so we can see that that's a sign of improper perfusion. And there's always one that I forget, and there's like puffiness, I guess, but there's like another major one. I always forget why. I'm always able to list like like five out of the six. I know I have listed six here, but there's like puffiness is like an extra one, or like inflammation. There's always one more that I don't forget that I can't remember. Pain, pins and needles, different, but your paralysis, pulselessness. Who can think about another one? Pallor, yeah, that's it. Always forget one of those. Pallor, so it's again from lack of circulation, a little pale. So these are the things you're looking out for. So they might have like a test question where it could be like the person had a hip surgery or they had a knee surgery, knee arthroplasty. Um, they have the cast going and they're not able to wiggle their toes. They're complaining about pain even though they've been on high dose opioids. They have pins and needles, so that's when you start thinking about acute compartment syndrome. Is it the cast is on too tight? Is it due to fracture? The fracture might be causing a impairment in the circulation, in which case they have to do the fasciotomy um real quick because it's an emergency because they can lose the limb. So let's kind of take a look at that fasciotomy. They're essentially gonna release the pressure there by cutting into the muscle. So something like that. But kind of slice it open, let the pressure escape, and then kind of sew it back up later. So your job is kind of just to detect it if it's happening and call the doctor because there's nothing you can do. It needs to be surgically managed. But of course, as a nurse, you're the eyes and ears, so you're the one that's gonna take the note of that. So that's why it's important with your fracture for people to look out for that so that they can. Then there's other stuff like you could have some drains, safety drain. That's the one you have to squeeze. It looks like a little hand grenade. Penrose, which is like a weird gravity-like thing. Hemovac, probably more likely to find that one in the hospital nowadays, or like a similar kind of little machine thing, like almost like a little vacuum that drains. Probably a fancier one. You'll probably I talked about compartment syndrome. You are going to use ice packs, not to be placed directly on the skin. So maybe grab an extra pillowcase and just kind of put it in there. And have something about a knee immobilizer. I really don't think you need to know that. I'll keep it just for fun, but just know it's again some of this information here might be a little extra. I think your key things is everything that's going to be highlighted. Um, anything that's highlighted or maybe some of the bold, I think is important. So this I think is important. So I'll highlight in bold for you. I think that's going to be your key. You don't need to know this. So I'm bold. Um, multimodal treatment for pain. So better to have a combination of morphine plus Tylenol than it is to just keep increasing the dose of the opioid. There can be some adjuvants medication like gabapentin, which is good for like a nerve pain. Um, for continuous femoral nerve block. Really don't think you need to know that. This is so extra. Talk about isometric exercises already. We talked about early ambulation, heparin levodopa for DVT prophylaxis. That's pretty much it for that. Are there any questions on osteoarthritis or the hip, some of the hip arthroplasty, knee arthroplasty? No? Alright. Oh, I forgot lupus. So true. Um, so then next up is just rheumatoid arthritis. Again, we said it was an inflammatory, so that's your key thing. It's systemic, it's inflammatory. All your symptoms are nice. Yeah, like Kaylin said, all your symptoms are some sort of inflammatory itis. I took a break from baking. Yeah. Yeah, my feet hurt. Yeah, so again, systemic autoimmune. We talked about how it's a inflammation of the synovial fluid. It's gonna end up affecting your cartilage, your bone, continuous inflammation. Some risk factors include things that cause chronic inflammation and all this other stuff here. Some of the we talked about in the chart. So this person can have fatigue, so it's just some autoimmune type thing. So fatigue, they can have low grade fever. But we mentioned how this is like a painful disease, of course. In terms of kind of making that direct comparison with OA, they kind of made some on like the stiffness. So what differentiates this one? And I'll include a picture while I'm at it. Yeah, it's not going to improve really throughout the day, simply because again, this is systemic inflammatory. Them moving or not moving doesn't particularly help much. It's just going to that inflammation is going to keep happening. Yeah, yeah, moving will probably make it worse if anything. So in terms of like making that direct comparison, specifically in the PowerPoint, it was morning stiffness will last longer than an hour, so they'll still have stiffness as well. Pain, stiffness. The pain can become worse over time. Okay. Movement can make it worse. This is going to be systemic and probably bilateral. Mention fatigue because it's an autoimmune condition. Another thing that might also be related to chronic anemia. So I guess maybe I'll do like this. Condition leads to chronic anemia. That's going to lead to low grade fever due to inflammatory response, swelling, which we mentioned. And key thing also is going to be finger contracture. So my mom has both OA and RA. So even worse for her. The rheumatoid arthritis has really completely deformed. Well, I wouldn't say completely. I guess she still has movement of it. It's not fully contracted or anything, but definitely deformed her hands and um, kind of, over the years started noticing when she started dropping things because her grip strength just kept weakening. So she was like dropping cups and stuff because of the weakening grip strength. I think that's got to do with like just the fact that it's autoimmune. I mean, I'll check the exact cause right now. I kind of just in my brain I was just like, oh, it's autoimmune. Let's see. Wow, the reasoning is so extra, it's crazy. Uh, the autoimmune part of it leads to release of very specific cytokines, which lead to a cascade of certain different liver hormones that leads to a whole bunch of other stuff. You really don't have to know it. It is kind of like yeah, it's kind of just like inflammatory condition equals anemia a lot of the time. These cascades. So like one example that I'm looking up here is that the inflammation has an impact on the kidneys. And we know that the kidneys make the erythropoietin, so that can also cause an impact on that. So chronic inflammation in general seems to have an impact on the production of red blood cells. So a lot of autoimmune disease might have accompanying anemia with it. And so it's really just a combination of the inflammatory process leading to reduction in production of red blood cells. Bottom line is don't worry about it. I don't think you'll ever be asked this on anything. Um, yeah, finger contraction, so we're gonna decrease. And then we set that the joints are gonna be warm because of inflammation. So really just hammering in. The key thing is this is inflammatory, while osteoarthritis is wear and tear. So that is going to be changing how this condition is managed compared to the other, as well as some of the autoimmune slash inflammatory based things. So the chronic anemia slash fatigue, that's another big differentiating thing that goes along with your RA because it's autoimmune, it's inflammatory. So these are the things to keep in mind, the things that really separate it apart. Okay. So your diagnostics are going to include signs and symptoms similar to the other one, but there's other labs, and we did talk about these other labs. Um, so what are some labs that you expect to be different due to chronic inflammation? Okay, yeah, the ANA titer. This is going to be positive. The ESR and CRP, these are inflammatory markers, and these are going to be high. Uh, type of what else could we expect to be high on here? Rheumatoid factor. It's in the name rheumatoid, so it makes sense to me. Rheumatoid factor positive on on most of these. So here they mentioned it's like it's positive on most people. Again, not particularly like if it's negative doesn't mean they don't have it necessarily. What else might be high if someone has an inflammatory condition? Yes, so that's an important thing that some people forget is that your white blood cell count can be elevated without any infection. It's just a inflammatory response. They can have an arthrocentesis to drain some of that stuff. Yeah. So you can drain fluid from there, or you can also like kind of access it. Means aspirate fluid gases or to release that can help us diagnose we can get some inflammatory cells in there. Right, so the main fluid, yep. So that Ashley mentioned the talked about the chronic anemia, so originating chronic. Okay. Boom. Pretty much it, yeah. So hopefully with this you guys can see like the different what really again the key word is inflammatory. So so now how is this gonna be managed? Instagram on I've never seen it. Yeah, so how man's this condition? Sorry, I was taking a call. Okay. What do you guys say? Blah, blah, blah. Let's see. DMARDs, yes. So your medication that's your gold standard is going to be methotrexate. So my mom takes that too. Methotrexate. Yes, so you want to intervene the earlier the better because it's going to be deformed. So the doctors, for some reason, didn't want to give my mom anything until it was very clearly heavily deformed. They didn't want to run any tests, kept ignoring her. Eventually, they like advocate. The nurse actually that was in the small little clinic advocated for her. They got all the tests and were like, "Oh wow, we totally couldn't tell from your massive deformities on your fingers and toes." And then now she's getting methotrexate. She's getting monthly, I think even maybe a little bit more than monthly steroid injections, which is I guess spoilers some be on here if it's not. I'd be kind of see what else you get. Blah 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 methotrexate. I think he might have told you guys to like really focus on methotrexate unless I'm thinking of, but the methotrexate can do certain things. So like side effects of methotrexate includes like at least the key things like liver inflammation, pancytopenia can happen. What else? Pulmonary issues, so pulmonitis, so inflammatory lung conditions, so assessment of ABCs, cough, shortness of breath, and it can cause a deficiency of like a folic acid deficiency. So you need to give yeast and folic acid, so take it with folic acid. Yeah, humor as well, another one. Guess I should do it like yeah. So the humor is also kind of given alongside. Given, And there's a whole bunch of side effects, but I don't think that one's as hard. Yeah, I think with that one, they want you to really, because I think it's gonna increase your risk of getting an infection. So and they want you to really, especially because it can cause, in particular, some pulmonary conditions. So rule out TB is something to keep in mind. Same thing here. I don't know why I didn't. But literally, the point of these meds is to. So that would be cough, low grade fever, have like potential blood thin sputum, rust or like blood thin sputum. Reports can be airborne thing, so you wanna really assess for that. Night sweats. Other meds I don't think are as important, but have them there for completion. So the hydrochloroquine, hydroxychloroquine, or hydrochloroquine. Wow. Put the brand name next to it in there. This one, just kind of think about it. Risk for vision loss and cardiomyopathy. Don't worry about too much. Other than that, I wouldn't really worry myself too much about it. Sulfasalazine, I'll just say it can cause kidney stones. So they might be on aspirin, Tylenol for pain. Inflammation for the aspirin side. They might be on steroids, NSAIDs, inflammation. So lots of different stuff. This person's gonna be on more stuff because the condition's more complicated. It's that inflammatory thing again keeps coming back. Um, we're gonna want PT and OT. We're gonna want proper balance of rest. They have fatigue, so it's always worth the manage their activity. So give them proper resting and stuff like that. Then the diet, so we talked about like reducing inflammation. I'm sure this can help for OA too, but here it's a bit more emphasized here because again, purely inflammatory condition here. You got to reduce all the good stuff: meat, sugar, alcohol. Can't have anything good. It's crazy. Apparently, strawberries and you can't even have lentils. They say get rid of all the good stuff. And here, I guess there's like a list of things to eat more. Salmon. I like salmon. Green tea. I like green tea. Omega-3 fish oils. Um, yeah. Surgery, the arthrocentesis can help drain um nobial fluid, inflammation stuff. But is there any questions on rheumatoid arthritis. So again, the key factor here is that this is inflammatory. So the medications and the labs reflect that this is an inflammatory can just really make sure you can differentiate them, understand what some of the inflammatory labs mean, what they're all about, and definitely understand methotrexate and Humira are probably the two I would focus on the most in terms of the meds, at least out of the special meds. So I would say those are the most important ones to know. And then some patient teaching is good for knowledge. I could see someone having like a question on like activity management because the patient has fatigue and things. So don't forget about some of the RA specific symptoms that occur due to the inflammation. Okay. Not gonna lie, I just found out that apparently I have to be at school at 9 a.m. for Kaplan test. I literally did not know it, and until about 10 minutes ago. Oh well. Yeah, I'm not worried about it. I don't think it even matters. But it's just like, oh, I didn't. Last one is lupus. Lupus. So this is another autoimmune condition. So again, we're gonna start thinking about all the stuff that can show up for autoimmune conditions and how they're triggered by here your keyword here is stress and what can cause stress, things like infection, different medications, hormonal changes. That's like with a lot of autoimmunes, it's chronic and progressive. But the key factor is that a lot of your issues are due to that inflammation. So inflammation of vessels. This is multi-system. So I think that's the key thing. It affects so many things. This condition affects so many different organs, especially the kidneys. That seems to be where the people with SLE, and there's different types of lupus. This is the one that they wanted to go over, but a lot of different organs are affected by this: kidneys, brain, heart, liver, the skin as well. And here again, I have does she have it? Oh, I did not know that. Oh wow, crazy stuff. But yeah, I did mention here how some of the early signs include the low-grade fever. So that low-grade fever is coming back again, a new rash or lesion, and we can talk about here. I kind of split off into each body organ or each body system, so we can kind of talk about it. But um, in general, we have that fatigue, that weakness. We can have some weight loss as well, so I kind of include that. So maybe like anorexia. There's potential for the bone marrow suppression. So whenever you think of bone marrow suppression, you should think about pancytopenia. But whoops, that's anemia, that's thrombocytopenia, and leukocytopenia. So low RBCs, low HNH, low platelets, low white blood cell count, or at the very least, immunosuppression of some kind. Okay, so person has fatigue, risk of dizziness, fatigue, thrombocytopenia, risk of bleeding, risk of infections. So now, in terms of some key factors, there's some dermatologic, so this is skin related. So what is your big thing with this condition that you might be able to see on the person's skin? Yeah, the butterfly rash. So this is called the butterfly, or it's also called the mallard rash. So we'll look at it. You made too many Rice Krispies? I guess I have to eat them. Oh, did you know there's a Kaplan test tomorrow?
Yes.
Really?
We're going at 9. 9 tomorrow, not 10.
I didn't even know I was going to school at 9. If you didn't if nobody told me I would have come to school at like 2:50.
Girl. Miss Girl.
It's only worth 10 points. Why are we gonna have to go? So here's a picture of what it looks like. Malar is the technical word for it. Butterfly rash is just because it kind of looks like it. Yeah, so we can kind of just post it. But just keep in mind that everyone with this condition is going to have the butterfly rash.
I'm sorry, did you say not everyone will have the butterfly rash or
Yeah,
everyone will?
not everyone.
Got it, thank you.
Okay, but that is what it would look like if it were to be the case. There's a few other things that could happen, but I think this is the main one. We're gonna try to really simplify this down. Because they do have the risk of the thrombocytopenia, they could have just general bruising as well. So maybe some bruising and fatigue. Okay. So now, in terms of neuro, what can you guys think about at this person? So if we have inflammation of vessels, that's a possibility, I imagine. The seizures, um, can think about like headaches. So like headaches, migraines, dizziness, cognitive impairment. I could see seizures from just the high pressure. So a lot of stuff that doesn't seem very fun. Maybe their vision, yeah, perfect. The vision problems as well. So headaches, a lot of horrible stuff here. And all of this could happen at once, or again, depends on the person, how it ends up manifesting. But this is the systemic version of lupus. This one's got a whole lot of stuff going on. Yeah. So even like alter level of consciousness. Cool. So now let's try to get a simplified stuff of what can happen with the renal. We know that this is one of the main complications that causes death in this person, renal failure. So what would be some signs of renal impairment? Yeah, the proteinuria, oliguria, perfect. Generally, fluid volume overload. One could get like patient can get glomerulonephritis, so that's the nephritic syndrome. Doodle Bob. That's because that's what Killing is doing. Do it again. No. It hurt you, so you might as well do it again.
No, it's too late for that. Goodbye, Chief.
Yeah. Yeah, that's the protein, yeah. So just keep always kind of keep in mind that this is like I mean, you thought you could just do that in the corner and nobody would listen.
Yeah. I didn't know your mic was that good. Mine's not on my computer. I'll tell them it's
It does sound better today.
slightly, slightly. I've been chugging down vitamin C zinc drinks and sleep.
Wow.
Was telling them the story about the protein shake thing, how I figured it out, that like the connection between foamy urine and protein.
I don't remember
Oh,
this.
okay.
Say it to
Well,
them.
I went to go and like rinse out a protein shake, right? Like the shakers.
Oh, it does get foamy, huh?
Yeah, and I put a whole bunch of water into it, and I was like, "Oh, it's so foamy. That's weird." And it was like mid third semester, and I was like, "Oh!" I made the connection. I was like, "Oh my god, the protein drink gets foamy like that because there's protein in it, and that's why the urine gets foamy in it because there's protein in it." I don't know. It was just like a shocking moment for me. A year and a half in.
So because this is glomerulonephritis is
But
nephritic, so like they could have hematuria with that as well. So the bloody they can have bloody pee with that. And in general they could have AKI, renal failure. All right, so we kind of broke that down. We already learned the renal, so we kind of have that for more fresh in our brain cells. Neuro, you can think of headaches, migraines, loss of level of consciousness. With that rash, think of it also kind of like DK bruising. So again, inflammation everywhere. I think it's important to keep in mind the pancytopenia and the fatigue and stuff. So then for now, with all that in mind, in general, I would just kind of have the autoimmune, start thinking of fatigue, low-grade fevers and stuff. With the autoimmunes, it comes in waves. Did they emphasize GI issues at all? Hmm, honestly, don't remember, but there's really not much to talk about over the GI for now. It really, it's they could have abdominal pain. Again, not everyone's gonna have all this active at once. Maybe some nausea, vomiting, anorexia, and I guess diarrhea as well. So it's very honestly pretty generic GI complaints, but it's pretty basic. Generally, honestly, with SLE, I just think about like everything's wrong with them. Every body system is affected, and it's crazy. Because a lot of these can just be can be you can attribute with the vasculitis. So a lot of this you can attribute with just very generic. But what is the bad thing that can happen with your with your renal? What's the bad thing that can happen with your GI, pulmonary, and it's probably in there. So with yeah. So it's not a fun condition. And then cardiovascular. So what are some symptoms that might occur with this one? All right, tell me your joke.
oh,
What?
you knew.
Oh, okay. Kaylin wanted you guys to know. Carditis? Pericarditis. That was her joke. I liked it.
Eddie the platypus. The vasculitis. It helps for SLE. We're on SLE, right?
Yes.
Because a lot of the symptoms end in itis. So it's like any of the inflammation things will probably be the right choice.
I want specific about was different, I guess. Pericarditis later, I suppose. But it kind of comes with chest pain. So wow, that
Hereditary chest pain.
yeah, chest pain, palpitations, all of these things. When you think about heart stuff, like oh, these are the first things that come to mind. I'm sure. You also have pleural pain, like in respiration, pain on this, and pleural friction rub. So that's the kind of one where you tell them to stop breathing. listen, and if you still hear the rub, that's a friction rub from the inflammation of the pericardium. But really, just kind of think of general heart stuff. You'll probably get to the right idea in terms of this. But here you can see just how much is going on here. And of course, I don't expect you guys to memorize every little line. That's not realistic. But it's just kind of clustering everything down into the idea. So you know there's hard stuff going on. A lot of this, if you see this on a test, you think, oh, that sounds like hard stuff. You should be able to look at some of these and be like, that sounds like renal stuff. The headaches and the migraines and the upper level conferences, that sounds like neuro stuff. Um, some of the specific ones, I guess I'll like highlight to make sure the butterfly rash, the malar rash, you understand that that's one of the potential signs and symptoms. They might not even write it down. They might actually just describe the shape of it in the question, maybe. Um, some of the things that might be again specific autoimmune specific stuff, maybe like low grade fevers, fatigue, weakness. Okay, now pulmonary. So again, let's add in an itis, pleuritis. What else might be there? Pleural effusions, perfect. Pleural effusions. They have pneumonia is another one that could happen. Difficulty bleeding, blood tint sputum. Okay, if they have pleural effusions, then we'll need to do a thoracentesis, get rid of some of that stuff going down. They could have crackles in the lungs. They could have diminished lung sounds, low SiO2. Again, you can kind of just if you see stuff like this on a test, you think that looks like lung stuff. And you're probably right. Like a lot of this very generic like lung problems. So that's the advantage of clustering things down. Instead of memorizing every little line, you could instead of memorizing like this, and this, memorize the big picture topics and then kind of build your case from there. We already talked about GI. Yeah,
No,
Losa,
spoot.
Losato 2,
Spoot.
Crackles. What?
It looked like spoot.
Spook?
It looked like spoot.
Does it?
That's what I read it as.
Interesting.
Think,
I don't even know how you read it. Spook? The T?
uh, I don't know.
Wouldn't that be pronounced spot? Bro.
My hand.
And then musculoskeletal. So something that ends in itis, arthritis. We kind of just talked about a lot in extensive detail. And tenderness. Um, effusions in the joints, which is why they would have to drain some of the fluid in the joints. In between. Yeah, this one's a symmetric one. Kind of makes sense. This is a immune, autoimmune, just like the RA, it's autoimmune, so it's also systemic.
Give him that attitude.
Huh?
You sounded
You
like
thought that was attitude?
I heard it as attitude.
You think so?
Yeah.
That's crazy. Okay.
Gaga.
Okay. Electrical systemic inflammation. I'm just a sassy. I kind of am. Am-
Wait. I have a stupid video
What?
of you from the end of the 220th
Oh
thing
yeah.
being like what was it? You're posing with
I'm like
the
posing,
you're posing
posing my
and
hair.
just you hear Bella, the other tutor in the background saying, ah, he's eating again.
I was slaying Andy at the same time.
I had a cookie in my hand that day.
But yeah, that's everything here
No.
for some of your manifestations. So again, try to just really cluster it down into the big picture, and then your brain can, especially with it's like we have the answer choices on it. You're not going to get any fill in the blank, so that helps a lot. You can just kind of denote that as neuro stuff, renal stuff, heart stuff, lung stuff. So some of the labs, this will look a little familiar. So we'll have DNA titers,
Wow.
rheumatoid factors. Yeah, your RH factors, ESR and CRP. So again, these would be high. Your NA titers are non-specific, but for the most part, most people with SLE will have positive. Rheumatoid factors as well, positive. A lot of this inflammation stuff will be there. There's something I know he mentioned C3, C4. That's related to a cytokine cascade that I had to learn in microbiome, and then never
Oh,
comes up ever again. And it won't come up here either, so don't worry about that. And it's not even there. LFTs, yeah. So this is going to be elevated due to maybe medications, and I'm sure the condition itself. I know we didn't list it up here, but I believe the condition itself have an impact on that. I go for SLE complications. Oh, sure. Like the lab. Yeah, yeah, yeah.
pericarditis.
Pericarditis.
Carditis.
I saw a video. So here, like we're talking about, like want to assess their BUN and their creatinine. The video was like their bun over their bun over cruh. It was like
What?
the bun over cruh, the bun over cruh, and it was like,
It's your boy.
oh, it's
Oh,
yeah, bun over cruh. So it'd be like the bra ratio. So it was like bun over cruh. It's the bra ratio or whatever. I'm kind of getting. We talked about the BUN creatinine. We know that renal failure is one of the big ones, so makes sense that that's gonna be something we're gonna do. We have potential for pulmonocardio, pulmonocardiopathy. Yeah, no, pulmonocardiopathy, pulmonomyopathy, whatever. You guys get what I'm saying. Rule out pulmonary or to assess for pulmonary or cardiovascular use. You guys already mentioned the echocardiogram as well. Yeah, yeah, the C3, C4, but like I was saying before, that's like relating to uh inflammatory cascade that you're like seriously not gonna be tested on. Yeah, don't worry about that stupid, oh my God, stupid inflammatory cascade. There's so many of those. For micro, I memorized them because that was what we, in microbiome is just on memorization. So memorize the cascade, and it's like Jesus Christ. I wouldn't worry too much about it, but I'll include it here just because.
yeah.
The 3C and 3-4, they're low. Why? Honestly, I don't remember what the cascade is. I memorized it for that one test, and that was it. But it does have to do with inflammation. But I wouldn't worry too much about it, honestly. And then the echo helps to see for um pericarditis and uh, maybe some pulmonary hypertension or something. All right. The next focus is really just the management. There's lots of stuff to do with SLE, but again, if you kind of just break it down to the system part of it, really focus in on the fact that this is autoimmune. So how stress affects autoimmune conditions. Um, kind of get alongside with your RA, really get into the idea of some of these inflammatory markers. Then there's a lot of crossover, and a lot of this starts to make a little bit more sense that way, without having to be like hyper memorizing every little line. And so for the management, treatment, spa day, yeah, like the warm bath that could help you with the pain, inflammation, and stuff. There's a lot of stuff here. But yeah, other than that, what else could be management? So this inflammatory condition. So two things that should come to your mind when you think about inflammation. Yeah, NSAIDs and steroids. Perfect. NSAIDs. Steroids. Yeah, NSAIDs are going to be better for this one because this one's a direct inflammatory condition. So the Tylenol's gonna probably not help too much with the. I mean, it's gonna help a little bit with the pain, but NSAIDs are gonna help with the pain and they're gonna help with the inflammation. So this is SLE is an inflammatory condition. And then the previous one we already talked about the side effects of these two. I'm not gonna beat that horse. We already talked about like GI bleeds for both of these. Honestly, how you're gonna want to assess for um immune weakened immune system. So I'm not gonna mention it. Your methotrexate. Same kind of idea. It's immunosuppressant. Depends. It's autoimmune still. We talked about how you need folic acid, LFT check, because it affects your like renal, and then I think your steroids can have an effect on the sodium, because kind of like in the Cushing's again, you can kind of think about the Cushing syndrome a lot for your side effects of steroids, because of the effect on those aldosterone receptors. It starts the hypernatremia, so low sodium diet also helps with that. Yeah, helps with the water retention too, because FBO, because we're having no problems. Then flare, but yeah, good stress management. So management of stress. So what else? There's the hydroxychloroquine, monitor blood pressure. So maybe I will just because there's so much stuff. Said this, we said that. Hypernatremia, hypertension. Again, you can always think about that. Folic acid, yeah, folic acid, methotrexate, you want to get full of it. Management of stress, SLFTs, and bleeding. The low sodium diet, oh yeah. So combination of renal impairment leads to fluid buildup, FBO. And I know that when you do have renal impairment, we do have delusional hyponatremia. That's kind of like a weird thing where it's like you can have um low salt, but at the same time the salt also doesn't help with the retention. So it's kind of a combination of that. But as long as it's not in critical range, it's more tolerable and more manageable. But another reason would be that the steroid use can lead to increased sodium level. So again, when you think about side effects of steroids, you can the think about Cushing syndrome and some of the side effects of Cushing or signs and symptoms of Cushing's. That those signs and symptoms of Cushing's will be like exaggerated versions of your short-term side effects of steroid use. So because the excess cortisol will have an impact on aldosterone, like I mentioned previously, the aldosterone receptors. Aldosterone's purpose is to contain salt and waste potassium. So maybe a low sodium diet and then kind of like again maybe like assessment of electrolytes in general. So maybe make sure that the salt is not too high and make sure that the potassium is not being affected. But then, there's other factors to take in mind. So if you have general renal impairment, some of those numbers might be thrown off on top of that. Only if kidneys are impaired. Um, It's like a little combination, like I said, the steroid use and side effects of steroids, Cushing syndrome, because those effects from Cushing syndrome are as a result of the steroids. So that's stuff like that. If they're going to be on high dose chronic, then that's when you start really thinking about it a bit more. So in general, I would just say think about electrolyte imbalance of some kind. When you think about retention, think about typically it will be a low sodium diet, um, which also helps with the heart as well. So, but remember, this is a very complex condition because it affects so many different things. So it ends up being kind of like a little game of what can we tweak without killing you? What can we tweak around and make so to make things function good enough? It's really difficult. Really, it fix everything that's happening here. Talked about mentioned a few times, being careful with it. Oh, sorry, my internet might be too bad. All right, were you able to hear me okay? I kind of just said it's kind of like a difficult little game of trying to fix the little things without breaking something. Oh, that hurt. Why'd you take that?
Okay,
August?
that's an old picture.
When did you take that picture?
I don't know.
You just always find ways.
Yep, that's correct, Shawty.
So careful with the sun. You guys mentioned sunblock, sunscreen, limit time in the sun
I need a
because of
box cover.
photosensitivity.
I'll be back.
Avoid triggers. So this is autoimmune and stress is a big thing that occurs here. So all of that. Honestly, that's pretty much it on this. Any questions on any of the three conditions we talked about? I'll give you guys this done and then this little bigger, slightly more detailed chart of the condition. So now we talked about that. We even talked about the little history. So you managed to get this one done in pretty good time. Any questions? If not, we'll stop.